in as much as possible, I'll want us to, within this period, um, expose you to some basic ophthalmology that will be very relevant to your practice as family physicians, make you very relevant to the communities you are going to serve. I'm sure we cannot do all of ophthalmology with just these few sessions of lectures, but at least you should know some basics, because like I said initially, as family physicians, you're supposed to know a bit, at least, about everything. Yeah, and the eye is very important. There are lots of people who come to the eye clinic or like to your general clinic with complaints about the eye. You should have some idea what to do before you even think of referring. And when you are referring a patient, it's good to know what the patient is likely to go through so that you can appropriately counsel the patient. So red eye for the family physician is our topic today. Throughout this talk, I'll be mentioning some of the causes of red eyes, the presentations, and then, hello, am I audible? Hello?
Yes.
Can you all hear me?
Yes.
All right.
I had to mute.
All right. Sorry, I think my video has come. Okay. So, red eyes constitute one of the major reasons why people come to the eye clinic. Sorry, I'm trying to adjust my video. Sometimes I move out of my computer camera. So there was a small button where I could see myself. I no longer can. All right, yeah, it's back. It helps me to know whether I'm well positioned. All right, so for the family physician, red eye is a frequent presentation. And the last time I said about almost 3% of people who come to your clinic will come with complaints of with some complaints about the eye. Now of this number, about 40% of them are going to come with presentations of red eye. We need to know how to be able to classify and triage these red eye presentations. Which of them need urgent treatment or referral? Which of them need treatment but can wait a while? And which of them don't need any treatment at all? So by the end of the presentation, I'll be going through a myriad of red eye conditions. And we should be able to decide when we encounter such, okay? Yeah, so there are lots of things that can cause red eye. Some of them may be self-limiting, benign, whereas some of the red eye presentations may be associated with life or sight-threatening events. Okay, so there are some disorders that can rapidly cause blindness, like infectious corneal ulcers, angle closure glaucoma, traumatic or post-operative endophthalmitis, which is in the globe itself, gonococcal conjunctivitis, chemical injuries, ocular trauma. These are all potentially sight-threatening. There are some life-threatening red eye presentations like orbital cellulitis. I'll be mentioning it because if you don't manage an orbital cellulitis, well, not only are you going to lose vision in that eye, but you also stand a chance of developing complications that can be life-threatening as well. For the sake of this presentation, I found this material very useful, and I want to acknowledge those who worked on this. It's a brilliant material for my presentation on red eye. I came across it, and I couldn't take much out, so I want to give the credits of the slides you'll be seeing to this book by the American Academy of Ophthalmology titled Managing the Red Eye. Okay, just some few excerpts from the Community Eye Health Journal that was published in 2005, also on red eye. I just chipped in just a few of that. Okay, so like I said initially, you should be able to differentiate those red eyes that need immediate treatment, those that need treatment within a few days, and those that do not require treatment at all. Patrick, please, when it's about 15 minutes to the end, kindly alert me. All right. So it's quite long, but I hope you find it very useful and very interesting. Okay. So subjectively, people that come to the eye clinics will complain of decreased vision, pain, or redness of the eye. And as I said, redness of the eyes complaint may constitute almost about 40%. A research that was done in an eye clinic in Ghana, in Boko, some few years ago, they came up with that number. And that number resonates with findings elsewhere on the globe. Red eyes are very common eye presentation, and we should be able to characterize these complaints through history and examination. Yeah, so the types of red eye disorders, um, they can be classified as red eyes from mechanical trauma to the eye, or from chemical trauma or injury, or from inflammations or infection of the eye. In order of decreasing severity, these are the 8 causes of red eyes. Okay, so in order of decreasing severity or urgency. So top on the list, we have chemical injuries. Then we have angle closure glaucoma, then ocular foreign body, corneal aberrations, uveitis, conjunctivitis, ocular surface disease, and then subconjunctival hemorrhage. Some of these etiological factors may overlap. Okay, for example, you may have a conjunctivitis that may result in what do you call it, some corneal aberrations or corneal ulcer, or you may have a corneal foreign body that can result in a corneal aberration, and then there can be secondary infection, conjunctivitis, or keratoconjunctivitis. Or you may have um, maybe some uveitis, okay, as a red eye, that can later result in an angle closure glaucoma. So some of the etiological agents may overlap. So these are the top possible causes of red eye, like I've said initially. So trauma, chemicals, infection, allergy, and then systemic conditions. Some of the symptoms in people presenting with red eye include itching, burning, foreign body sensation, and localized tenderness of the eyelid. And these classic symptoms really suggest the underlying cause of the red eyes. So someone who has red eye and complains of itching most likely has an allergy, an allergic conjunctivitis or keratoconjunctivitis. Okay. Someone with red eyes who complain of burning sensation um, may have disorders of the lid. For example, if there is a condition we call entropion, which is an inward rotation of the margin of the eyelid, so that the eyelashes are now rubbing on the surface of the eye or on the surface of the cornea. That can give some burning sensation and also some foreign body sensation. Conditions that predispose to dryness of the surface of the eye, a condition technically called keratoconjunctivitis sicca or dry eye syndrome. People can present with dry eye and then complain of burning sensation on their eyes. Foreign body sensation, like I've said initially, if there is a foreign body on the eye, or there is an abrasion on the cornea from any cause. It could even be from the person's own eyelashes, from entropion, or from trichiasis. That's when you have a misdirection of the eyelashes rubbing on the surface of the cornea. They can give foreign body sensation, and they can also present with red eye. Or localized tenderness on the lid. In this case, you may find that a particular portion of the lid may be swollen and tender. So typically we have two conditions, rhodiolum and then chalazion. I'll go to them in detail so that you'll be able to learn to differentiate between those two conditions. Okay, so some more symptoms associated with red eye. When the patient complains of deep, intense pain, it could be caused by abrasions on the cornea, iritis, scleritis, acute glaucoma, and even sinusitis. They can cause deep, intense pain of the eye. And then pain of the eye that is worsened or elicited on exposure to light, that's photophobia, can be caused by iritis, which is inflammation of the iris, or uveitis. Last time I mentioned that the uveal tract is made up of the iris anteriorly, then we have the ciliary body, then posteriorly we have the choroid, okay? So when there is inflammation of the iris or the choroid, it is uveitis, anterior uveitis, and that can give photophobia, okay? The person becomes very sensitive to light. And then acute angle closure glaucoma, where when the pressure inside the eye suddenly rises and there is edema of the cornea, it can also make the person very sensitive to light. And then they complain like halo vision. The patient complains of seeing rainbow colors around light. It's a typical presentation you find in someone who has a corneal edema from any cause. So corneal edema from an acute angle closure glaucoma, or even from uveitis. When the cornea is edematous, they can have this sensation of halo around light. What do you need as a family physician to be able to characterize and diagnose a red eye in terms of the major etiological groupings that I have mentioned? You don't need much. You need your Snellen's charts, your visual acuity charts. Okay. If you don't have the standard Snellen's chart where the patient sits 6 meters or 20 feet to read from the chart, you can have this pocket size Snellen's chart where you check the near vision, and then there are equivalents depending on what the person is able to see at that given testing distance. You can extrapolate it to the distant vision. Okay, but if you have the distant vision, that's the best. Okay, but in this case, if you are seeing someone who is 40 years and older, then you have to ensure that the person is wearing his near correction, okay, because of the presbyopia, okay, before you can extrapolate the near vision to the distant visual acuity. You need your light, you need topical analgesics like amethocane eye drop, and then you also need fluorescein to be able to stain for pathologies of the cornea. This is very important. And the fluorescein could come as fluorescein eye drops or fluorescein impregnated strips, like you can see in the picture here. So there is fluorescein at the tip. I don't know whether you can see my arrow. Can you see the pointer when I show you this one? Do you see it
Yes,
on the
we can
screen?
see the pointer.
All right, good. Yeah. So the fluorescein is actually impregnated at the tip of the strip. So you place this one in the conjunctival um, space, and then the tears of the patient is going to wet the tip, and then the dye is now, when the patient blinks, the dye spreads over the surface of the cornea. And if there is a pathology, you'll see it. Yeah. So if you check the vision of someone who presents to you with red eyes, and the patient's vision or visual acuity is not as it should, and I think by this time we know what the normal vision is. It's not 6/6, but it's any vision which is 6/12 and better is considered normal. However, if the patient, tells you that he has subjectively seen a decrease in the vision, then even when the vision is 6/9, maybe the person's vision was 6/4 or 6/5, and it has decreased because of some red eye condition. It is a condition that you have to refer to an ophthalmologist for further evaluation and management. However, majority of the cases may not have a decrease or poor visual acuity. For most of them, you should be able to manage them at your level. Yeah. So this is how I'm going to approach it. I'm going to approach it anatomically. Okay. So we shall look at the face, the adnexal, then the globe. We shall look at the various problems with these anatomical areas that can present with red eye. Okay. Just a recap of what we did during the last talk. The eyelid is very important. It protects the globe from injury. It also helps in nourishing the surface of the ocular. In nourishing the ocular surface with tears, and tears contain some vital substance required for the health of the cornea and other structures of the ocular surface. The eyelid is made up of the skin that's from anteriorly to posteriorly. You have the skin, we have subcutaneous parts, we have the muscles, the orbicularis muscle. Then we have um, some glands, hair follicle. Then around the base of the hair follicle, we have the perifollicular glands. Then we have this structure here, very important. We call them meibomian glands. They can be pathologies with any of these that can result in a red eye. Okay, so the first pathology I want us to talk about. If you look at this picture, you can see there's a swelling here. There's a localized swelling here on this part of the upper lid where my arrow is. Okay, this swelling may be tender or may not be tender, and it's called a hordeolum. Usually hordeoli or hordeolum for singular, commonly called sty. It's usually caused by blockage of the glands here, the ducts of the glands here, and there can be secondary infection. Okay, can cause very painful swelling of the upper lid. Then we have another condition we call chalazion. Okay, chalazion is caused by blockage of the gland from the meibomian gland, blockage of the secretions that are coming from the meibomian gland. These meibomian glands are located in the tarsal plate. The tarsal plate is a firm tissue that supports the upper lid. Okay, it helps to give shape to the upper lid. Okay, so and the last time when I was talking about tears, I said tears is not made up of just aqueous, but it has some mucinous components and it has some mucoid components, okay, or some lipid components. The lipid components of the tears is contributed to by secretions from the meibomian gland. So when you have blockade of the meibomian gland, it can result in swelling in the upper lid, but typically between chalazion and then hordeolum. Usually chalasia are usually non-tender, okay, but there can be secondary infection in chalazion, and that can make them quite tender. And how do you manage this? Usually, most of these are self-limiting by just applying warm compress. Okay, not too hot to cause burning of the skin, but not also too lukewarm either. By applying the warm compress, it helps to, especially in the case of chalazion, which is caused by blockade of the tubules or the ducts of the meibomian gland. It helps to liquefy the fats which have accumulated. and allow the fat to drain and the condition to resolve. If upon application of warm compress, the condition is not resolving, then we may have to refer for an eye care practitioner to do what we call marsupialization of the gland, like cut it open and then allow the content to come out. Okay. So the main goal of treating chalazion and hordeolum is to promote drainage of the ducts. That is what you do by applying the warm to hot compresses. Okay. If it is chronic, if it's not resolving, then you have to refer. Please, if there's any question at any point, kindly come to me and let me clarify. All right. The next cause of red eyes is blepharitis, which is inflammation of the lid margin. Okay. Um, so it will affect the eyelashes, the glands that surround the eyelashes, and they may sometimes be associated with dry eyes. Okay, because you have dry eyes when the tear film is not stable on the surface of the eye, and that could be due to changes in the constituents of the tears. The tears should contain lipid. So if someone has any inflammation of the lid, it will affect the glands that constitute or that produce out the constituents of the tears. Okay, so that can lead to symptoms of dry eyes. And what are some of the symptoms of dry eyes? The patient may present paradoxically with tearing, okay, because the eye feels dry. The nerves that are on the cornea sense that the eye feels dry. Information is sent to the brainstem, and then there is a reflex feedback to the lacrimal gland to produce more tears in an attempt to wet the eye which is dry. So even though someone with dry, someone whose eye is dry may rather complain of the eye feeling wet because of the reflex tearing as a result of the underlying cause of dryness of the surface of the eye. I hope that's clear. So they may complain of tearing even though their eyes are dry, or they may complain of foreign body sensation, or they may complain of burning sensation or pain on the eye. Okay, all these are symptoms of dry eyes. They may also complain of blurring of the vision because the tears are very, very important components of the refractive system of the eye. I said the other time that the cornea is even more important than the lens when it comes to refraction. But it's not just the cornea, it's the tears that cover the cornea. So when someone has dry eye syndrome, they may have blurred vision. That could be as a result of a refractive error. So because the surface of the cornea is not very smooth, light that's entering the eye gets scattered. Okay, and you may see that the vision or the visual acuity may improve with pinhole. Okay, so another feature of blepharitis is the skin will appear dry, and then at the base of the eyelashes you see these whitish waxy substances at the base. Okay, sometimes or they may be caused by some bacterial infections, most commonly staphylococcus, which is a bacteria which is part of the normal skin flora, can be a cause of blepharitis. So the symptoms are burning of the eyelid, as well as um, martering of the lashes, especially when the person wakes up. So this is a picture that shows some collarettes at the base of the eyelashes of someone who has blepharitis. How do we treat blepharitis? It's simply by lid and facial hygiene. So again, just like we did for chalazion and hordeolum, warm compress to help to loosen the deposits that are on the margin of the lid. Okay, and then we can also use baby diluted baby shampoo or um, ready-made scrap parts, okay, just to clean the lid margin, and then all those deposits that are on the lid margin, okay. So warm compress, and then you can also use dilute baby shampoo that is non-irritating, okay. Baby shampoos are usually non-irritating, so non-irritating baby shampoo to scrub the eyelid, okay. And then in addition to this, you also have to give artificial tears because blepharitis will usually come with dry eye syndrome. The patient feels uncomfortable. It's as if there are sand particles on the eye, okay. And you never get it wrong by giving artificial tears. Metal cellulose, some brands like Refresh Tears, Cool Eyes, you never get it wrong. Even if it's not dry eyes and you give it, it's not going to harm the eye in any way. So when you're able to identify blepharitis, in addition to the warm compress, you have to prescribe some artificial tears to make the person's eye feel quite comfortable and relieve the symptoms of dry eyes associated with the blepharitis. Okay. Some also add antibiotic ointment for application to the lids. Okay, it helps to make the lid feel quite comfortable. And then in cases that are not responding to this, you may have to give oral doxycycline 100 milligrams daily. This helps to or in most cases help to resolve most of the blepharitis. Okay, a very important cause of red eye is what we call preseptal cellulitis. You can see on the screen here. Let me see if I have this picture. Sorry. Can anybody tell the difference between this picture and the next picture? Of course, the diagnoses are written below the pictures, but can you, by just looking, look at the left eyes, can you tell any difference between the two eyes?
Difference between the two.
Sorry, can you come again?
Please show it again.
All right, so this is the first picture, and this is the second picture. All right. Yeah, any help?
So for the second one,
Yeah.
the eye cannot open because the two lids are all inflamed, and
Okay.
and the eyes also look reddish in.
Okay. All
Yeah.
right.
Yes. And it also look like it's having some tearing or inflammation,
All right.
yeah, like
Yeah.
pores like, yeah, in it, yeah.
Yeah.
Yeah. So
All
this
right.
is actually generalized. Yeah. In cellulitis,
Yeah.
it's actually more generalized on the second one, on this, yeah, the orbital
Yeah.
cellulitis.
All
Yeah.
right. I just realized that the second picture didn't show some features that I wish you see. I'm just trying to look for an image of an eye with a typical orbital cellulitis, so that you can see, because it's very, very important that you distinguish between a preseptal cellulitis and then orbital cellulitis, because orbital cellulitis is very serious. It is an ocular emergency, and it is sight threatening and also life threatening. Okay, when you have a case of orbital cellulitis, the patient requires admission and the patient requires intravenous antibiotics aggressively. Okay, whilst is monitored closely by an ophthalmologist or any qualified eye care practitioner. But preseptal cellulitis can be treated with oral medication, so the patient can be monitored on outpatient basis. Okay, I'm trying to good. So I've got this picture. Yeah, so can you see where my arrow is? I just Googled. Look at this picture. Can you see this picture?
Which one?
Okay, sorry. I'm not sharing that particular screen. Anyway, I think it's going to be. Let me move so that I can share that screen on my. All right. Sorry, I think it will be difficult. Anyway, so what I want you to get the difference between good. I think this picture is good enough. Yeah, if you look at these pictures for orbital cellulitis, then you go back, look at this picture for preseptal cellulitis. What strikes you is that even though there is periorbital swelling, the globe itself looks quite normal. Okay, the globe appears white. The globe is the eyeball. The eyeball appears white. The cornea is clear. Everything. And if you compare that to orbital cellulitis, the swelling is usually quite massive, and the eyeball itself may appear proptosed. It may appear to be displaced a bit anteriorly. It will be difficult for you to appreciate that in this picture. And then, in most cases, for orbital cellulitis, the conjunctiva will look very red. Okay, it will look swollen and red, a condition we call chemosis. And if you attempt to do motility of the eyeball or ocular motility, motility will be restricted in orbital cellulitis, and motility will be normal in preseptal cellulitis. Okay, and again, vision is likely to be intact in preseptal cellulitis. Maybe it's just the eyelids that are swollen and occluding the eye, but if you're able to part the two legs apart, the patient can see even up to the sixth line. But that's not the case with orbital cellulitis. Vision is most of the time decreased in orbital cellulitis. And because there is so much pressure going on inside the orbit of the eye, there will be compression on the optic nerve. So if you examine the pupil, you may notice that in severe kinds of orbital cellulitis, the pupillary reaction in that eye may not be normal. It may be sluggish, and then there may be what we call relative afferent pupillary defect (RAPD). It's a condition that develops when the optic nerves are asymmetrically affected. Okay, yeah. So these are the classic signs. When we have preceptal cellulitis, the globe appears normal. These are not really an emergency, even though it may progress to orbital cellulitis with time if it's not well managed. But orbital cellulitis are emergencies. Okay, so there may be swelling and reddening just like you have in preceptal cellulitis. Motility is impaired. There may or there may not be proptosis. And the patient usually may look sicker. The patient looks sick, more sick in orbital cellulitis compared to preceptal cellulitis. And when you do the labs, you may find out that there is significant leukocytosis. And then because of damage to the optic nerve compression, because of the pressure inside the orbit. In preceptal cellulitis, the inflammation or the pathology is occurring anterior to the structure we call the orbital septum. Okay, so it's not really into the orbit. It is anterior to the orbital septum. But in orbital cellulitis, it is posterior to the orbital septum. So whatever pressure there is transmitted to the optic nerve. That's why it's an emergency, because it can be sight-threatening and it can also be life-threatening. So because of pressure on the optic nerve, vision will be decreased, and there may be afferent pupillary defects, as well as the disc may appear edematous. Okay, so this is how you manage orbital cellulitis. You have to hospitalize, admit the patient to the hospital, send a consult an ophthalmologist to be involved in the management. You have to take blood for full blood counts and for culture and sensitivity, because you are going to start broad spectrum antibiotics. Okay, if it's not responding and you are happy, you are likely to get to be able to isolate some organisms from your culture according to the sensitivity to help you to manage the infection very well. Okay, and it can be caused by bacterial infection, sometimes fungi, not very common, but most of the time they are caused by bacterial infection. Okay, and orbital cellulitis could be as a result of a disease in the sinus. So for this case, you have to do an imaging, a CT scan. Okay, that will help you to know if there are associated sinus, paranasal sinus involvement. In that case, then you have to involve the ENT specialist in the management. Sometimes there could be abscess, okay, abscess in the sinuses, or even some subperiosteal abscess that may require drainage. Yeah, you may have to involve the ophthalmologist and the ENT surgeons in the management. Okay, so as I said, you have to start IV antibiotics. Antibiotics that have coverage for Staphylococcus, Strep, and Haemophilus influenzae, which are the most common organisms found in causing orbital cellulitis. If it's caused by some fungi, or if there is no improvement, or if there is subperiosteal abscess, then surgical management may be required. Okay. Some of the complications include meningitis and then cavernous sinus thrombosis, both of which are very life-threatening, unlike you have in preseptal cellulitis. I hope that's clear. Are you with me?
Yes, we
Hello.
are.
All
Yes,
right.
yes, Doc.
All right. Okay. So the next anatomical structure I want us to look at is the lacrimal system. Okay, the lacrimal drainage system. So we have the tears being produced by the lacrimal gland on the supratemporal aspect of the eye. Then after the tears are produced, they and then it finish its work, it needs to be drained away through the lacrimal drainage system. So like I said the other time, there's a punctum. You have an upper punctum, then a lower punctum. Then there is a duct that connects the punctum to the lacrimal sac. We call it the canaliculus. Okay, we have the lacrimal sac here. Then we have the nasolacrimal duct itself. Okay, so it should drain to a place behind the nose. Okay, so if there is any abnormality with the drainage, it can also result in infection of the nasolacrimal duct system that can also present with a red eye. Okay, so this patient has a dacrocystitis, which is inflammation of the lacrimal sac. Okay, and you are going to encounter in your practice that a lot of children or mothers will come complaining of their children tearing, even when they are not crying, and they are having recurrent discharge from a particular eye or from both eyes. That could be because of a condition we call congenital nasolacrimal duct obstruction. I'll talk about this when we are talking about pediatric ophthalmology. But in most children, the nasolacrimal duct may not be patent, but by the time they are about 12 months old or 1 year old, most of them will spontaneously canalize. So for them, you have to teach mothers to massage the lacrimal sac daily. Okay, if it doesn't respond, if after 1 year they still show symptoms of the lacrimal duct obstruction, then you may have to do what we call probing. The ophthalmologist will pass a probe through the duct to uh, to be able to make the nasolacrimal duct patent. So we probe and then we do irrigation. When they are having recurrent discharges, they may need some topical antibiotics or some systemic antibiotics, depending on how severe the infection is. There may also be acquired nasolacrimal duct obstruction. These could be as a result of trauma or recurrent inflammation of the lacrimal sac. Okay, so recurrent episodes of inflammation of the lacrimal sac can result in stricture of the drainage of the nasolacrimal duct system. Okay. Is there any question as of this point? So we now move to the ocular surface, to ocular surface disorders that can also present with dry eyes. So just a brief recap of the anatomy. The conjunctiva is made up of three main parts. Okay, we have the part that covers the globe itself, called the bulbar conjunctiva. Then we have the part that covers the inner part of the legs, the upper and the lower legs. We call that the palpebral conjunctiva. Then you will see that if you look at the palpebral conjunctiva, when it gets up here, it reflects before it comes to join the bulbar conjunctiva. This part is what we call the fornix. Okay, so the conjunctiva here is called the fornicial conjunctiva. Okay, yeah. There can be a lot of problems that can happen to the conjunctiva that will result in red eye. The conjunctiva normally is transparent. It contains vessels, and most of the vessels are not dilated. The vessels become dilated when the conjunctiva becomes inflamed in a condition we call conjunctivitis. Okay, yeah. So there are many things that can cause conjunctivitis. Could be from infections, like from bacteria, viruses, or allergy. Okay, so sometimes knowledge of these symptoms can clinically help you to be able to distinguish whether this is being caused by a bacterial etiology or viral, or it could just be allergic. Okay, yeah. So the nature of the discharge in someone with conjunctivitis is very important. If the person has a bacterial infection causing the conjunctivitis, usually they will have some purulent discharge. Okay, viral conjunctivitis usually will produce clear discharges from the eye, whereas allergic conjunctivitis will result in discharges that are watery, and they may have some white, stringy mucus, okay, in addition to the clear, watery discharge, typical for allergic conjunctivitis, okay? Yeah, and if you suspect viral infection, you have to palpate for the pre-auricular lymph nodes. They may usually be enlarged, and that's typical for viral infections. You don't usually get it in bacterial infection. How do you treat conjunctivitis? If it's bacterial, so topical, there are broad spectrum topical antibiotics, okay, that you can apply 4 times a day for about a week. So you can choose antibiotics from the groups of the aminoglycosides, like gentamicin, or the fluoroquinolones. So we have many generations. We have ciprofloxacin, which has been abused quite most of the time. We have ofloxacin. Okay, it's a drug which is active against most of the gram-positive bacteria that will cause conjunctivitis. Erythromycin, sulfacetamide, and a host of other topical antibiotics. So in addition to your topical antibiotics, warm compresses. However, if the conjunctivitis is not improving within 3 days, it's an indication you have to refer to an ophthalmologist. Okay. If you have someone coming with this particular typical kind of purulent discharge, it is gonococcal infection until proven otherwise. So for this patient with copious purulent discharge, usually hyperacute in presentation, you have to inquire about symptoms of discharge from the urethra. So some purulent vaginal or penile discharge, because when someone has urethritis from gonorrhea, and then the person does not um, wash or clean the hands very well, and then the person use the hand contaminated with the bacteria to infect the eye, you can get this kind of Neisseria gonorrhea purulent discharge. Okay, so when you have this purulent discharge, especially in people who are of the reproductive age, you have to rule out gonorrhea until proven otherwise. It is gonorrhea until proven otherwise. Okay. And this one, you need to be quite aggressive because the Neisseria gonorrhea organism can easily cause perforation of the cornea. In children, when they have conjunctivitis within the first month of birth, we call it neonatal ophthalmia neonatarum, okay? And some of them could be caused by some sexually transmitted infections like gonorrhea, chlamydia. Those that are actually caused by gonorrhea can be very, very, very sight-threatening and even life-threatening. So those are also ophthalmic emergencies, okay? So when you see something like this, you have to clean very frequently with some moist, clean gauze or cloth, and then you apply your topical antibiotics very, very, very frequently. Before that, you have to take a specimen like a swab to send for culture and sensitivity. Even before your culture and sensitivity, you can do gram stain, okay? And if it is Neisseria, typically you want to find a gram-negative intracellular diplococcus, okay, typical for Neisseria gonorrhea, so that even before your culture results come, you have an idea what you are dealing with. And if gonorrhea, you have to hit hard with some of the the fluoroquinolones like ofloxacin. Okay, brands like aflacin are very good, and your ciprofloxacin. But in that case, you have to give your topical medications very frequently. Sometimes you start with as frequent as every 30 minutes for the next 2 hours, and then you go every hour, okay, for about 24 hours until you see improvement. Then you reduce it to about every 2 hours or every 4 hours, okay. All right. Then we have the viral conjunctivitis, okay. Yeah, these are usually self-limiting. They may not require any antiviral medication for treatment. However, they can result in lots of discomfort on the eyes. So you can give them lubricants and artificial tears. What you have to be cautious about is the use of steroids, because steroids will actually make viral conjunctivitis worse and even go on to involve the cornea. Some viral conjunctivitis may be highly contagious. So if you find out that people in its immediate vicinity are also having red eyes, it should draw your mind to an epidemic of viral conjunctivitis. So it means that person needs to be isolated. Otherwise, it spreads very, very, very quickly. Okay. So if the person is a hospital personnel or a daycare worker, food handler, or if people who are in similar occupations who have had contact are developing it, then you have to alert them and then isolate these people, okay? Just like I said for viral conjunctivitis, you may be able to palpate the periauricular lymph nodes, all right? Yeah. And then supportively, you can give some ointments like tetracycline, not to 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 cure the virus, but it helps to make the eye feel comfortable. They will have dry eye symptoms, so your ointment as lubricant, then you can give artificial tears, okay, just to help keep the eye comfortable from the dry eyes that are a complication of viral complication and viral conjunctivitis. Okay, next we shall look at okay, yeah, so that's what I've said already. Watery discharge, highly contagious, palpable lymph nodes, okay? And they may present with pain, photophobia, and decrease in vision. Then we have allergic conjunctivitis, or we could also have allergic keratoconjunctivitis, okay? Typically for allergic conjunctivitis, you have watery discharge and some mucus in the discharge, usually bilateral. And if you examine the eyes, when you vet the upper eyelid, you see some typical papillae, okay, swelling on the tarsal conjunctiva, okay, very, very typical. Some of them could be very, very giant swellings that can give the patient sensation of foreign body on the eyes. It feels as if there is stones or sand on the eyes. Okay, so in this case, the patient may have some other conditions that could suggest allergy, like asthma, atopic dermatitis, or anything, or there may be a history of recurrent itching of the eyes. So you give your topical antihistamines, or like that will work immediately to relieve the patient. And then you also give something for long term. So the mast cell stabilizers like the sodium chromoglycate, okay, that will help to reduce the frequency and the severity of future attacks of allergic conjunctivitis. So like I said, they may be associated with some systemic conditions like hay fever, asthma, eczema, and then contact allergy, okay. You give your antihistamine and then decongestant eye drops. And then for those that have other systemic associations like itchy throat, itchy ears, or if the allergic conjunctivitis is very severe, you may give some oral antihistamines like chlorpheniramine or cetirizine, okay, that they take at night, okay. I mentioned neonatal conjunctivitis. This is something that we shall talk about when we are discussing pediatric ophthalmology. It's very important. And then on the ocular surface, you may have what we call subconjunctival hemorrhage. This is a very common presentation. It can be very, very frightening for the patient because there is no history of trauma to the eye. The patient just spontaneously notices that the eye has become red. And when you examine, you see this bright red discoloration under the, hello? Hello?
Yes.
Yeah.
Hi. Yeah, hi.
Good.
Hello.
All right.
Hello.
You're good. Yeah. I thought someone had a question. Patrick, you are talking, but your line is breaking. Can you please come again? You are inaudible.
I said, what with you?
Hello?
Hello.
Yeah.
I said, what with you?
Sorry, I still can't.
He's hearing you well.
Okay. All right, that's fine. That's fine. Yeah, so let's take note of this particular one, subconjunctival hemorrhage. You may notice it in people who have maybe bleeding diathesis or some coagulation problem, or people with very high blood pressure, or after some Valsalva maneuver, like a woman who has just delivered during, if it was spontaneous vaginal delivery, whilst the woman is pushing, that there is so much pressure from the Valsalva maneuver, it can cause some of the small blood vessels in the conjunctiva to break and result in bleeding. And usually it will have a very distinct margin and it will be bright red. It's not something that requires any treatment. It's going to resolve on its own within about 2 weeks, okay? So that is subconjunctival hemorrhage. As I said, you need to ensure that you do some studies to rule out problems with hematological coagulation, okay? Yeah. You do this if after you do fundoscopy, you see that there are some hemorrhages on the retina as well. Okay, otherwise it doesn't need any. Yeah.
Hello? Yeah.
Hello? Yeah.
Yeah. We sometimes see it in neonates, in newborn babies. Yeah.
Yeah. So during the time of delivery, if there is any trauma, some mild trauma to the eye, it can cause some of the conjunctival vessels to break and result in bleeding under the conjunctiva. It doesn't require any treatment. The patient just needs reassurance that is going to clear. So whether it's in a unit or it's in an adult. But if it's an adult, make sure that your pressure is fine, and then also examine the fundus to ensure that there are no associated retinal hemorrhages. If there are associated retinal hemorrhages, then you have to do some hematologic coagulation studies. Okay, yeah. So someone who is on anticoagulation medication like warfarin or aspirin, they may have these kind of spontaneous subconj hemorrhage. Okay, yeah. The next thing I want us to look at is dry eyes. Okay, this is very common in my clinic. It always stops the reasons for OPD attendance, and that's a trend elsewhere. Most people will come to the eye clinic or to the general clinic with complaints of dry eye syndrome. The patient may not tell you that my eye feels dry. Just a few who will tell that my eyes feel dry. But usually they will come with complaints of gritty sensation on the eye, tearing, like I've mentioned already. So the eye feels dry. The corneal nerves send information to the brainstem that the eye feels dry. Then there is feedback to the lacrimal gland to produce tears. Okay, so there is, paradoxically, there is tearing, but the eye is dry. Okay, and dry eye syndrome is a multifactorial pathology. There are lots of things that can cause it, but the underlying mechanisms are: one, there is unstable tear film. There is usually inflammation on the surface of the eye. That's why the eyes can become red. Okay, and there is high osmolarity of the tears. Okay, yeah. So as this is going on, there is distraction of some of the structures on the ocular surface. Okay, so you need to break the cycle at one point by maybe giving lots of tear foam substitutes or some anti-inflammatory agents to reduce the inflammation and the further damage occurring on the surface of the eyes. Okay, yeah. So the technical name is keratoconjunctivitis sicca. So presents with complaints of burning, foreign body sensation. I've mentioned paradoxical reflex tearing. And then typically, patients who have dry eyes, they may notice that their symptoms are worse when they are driving or when they are in the car and the wind is blowing on their eyes. Okay, when someone has dry eyes and then there is wind current on the eye, there is evaporation of their little tears, and the dry eyes symptoms become even worse. When they are reading, you know, when you are reading or when you are watching television, you don't blink as fast as normally you would. Normally, the normal person should blink about 12 times within a minute. Okay, but when you are reading or when you are watching something which is interesting on your laptop or on your TV, you end up blinking less frequently. Okay, and that's one will result in more evaporation of your tears. Okay, so dry eyes syndrome, it could be as a result of more evaporation of the tears or as a result of decreased production of the aqueous or some other components of the tears like lipid. Okay, so someone who has blepharitis or maybe some chalazion and there is inadequate production of the lipid components of the tears, their tear film may not be that stable and they'll come with lots of complaints of dry eye symptoms that are made worse when they are reading, using a computer, watching TV, driving, or after air travel. Okay, and one thing you can ask is when they experience these symptoms and they close their eye for a while, they will confirm that they feel better after they have closed their eyes for a while. Because when you close your eyes, your little tears that you have is now able to nourish the surface of the eye and let all the symptoms go down. So typically that is how dry eye symptoms appear. So you will not get it wrong if you assume that, I mean, everyone who complains of burning sensation and foreign body sensation and paradoxical reflex tearing has dry eye syndrome, even though you have to examine to ensure that there is actually no foreign body. Okay, so your history will be important. If the patient was doing something that you think a foreign body can lie on the eye, you have to examine and ensure that you take out that foreign body. Otherwise, you have to manage as dry eyes. Okay, and the condition is usually associated with aging. As you grow, the components of the tears decrease. And then certain systemic conditions like rheumatoid arthritis, Stevens-Johnson syndrome, people who have had chemical injuries, there is distraction of, there are some glands in the conjunctiva we call goblet cells, okay? They produce mucin. And the mucin is very important in helping produce a stable tear film for it to stay on the surface of the eye. When someone has had chemical injuries or ocular pemphigoid, then the goblet cells are abnormal and the tear film becomes unstable, and therefore the eye becomes quite dry. Okay, certain systemic medications like these calcium channel blockers that we use in managing hypertension, we should bear in mind that they can also have side effects of dry eye syndrome. Okay, but it doesn't mean the patient should be taking off the oral antihypertensive medications he's taking. Some medications like antihistamines also have dry eyes, can have side effects of dry eye syndrome. You should be aware so that if the patient complains, you give tear foam substitutes like the metal cellulose 0.3%, and for the patient to feel comfortable and for the patient to continue using those systemic medications. Okay, so artificial tears, some also whose are very severe will also need some cyclosporin eye drops. These are anti-inflammatory medications because underlining the mechanism of dry eye syndrome, there is inflammation, there is tear form hyperosmolarity. Okay, the tears become very concentrated and hence very toxic to the surface of the eye. Okay, so artificial tears to supplement the deficient tears, and then ideally, if you get artificial tears that are not preserved, because some of the chemicals used in preserving these medications can themselves also cause dry eye syndrome because some of them destroy some of the epithelia of the conjunctiva as well as the cornea. Okay, patients who are on chronic topical medications like patients being managed for glaucoma, with time will come complaining of symptoms of dry eye syndrome. Okay, and you just have to supplement their medications with some artificial tears. So lubrication at night, especially, what we normally prefer is tetracycline ointment because tetracycline, apart from its lubricating effect, it also has some anti-inflammatory effect, okay, which helps in managing the dry eye condition. Some people whose condition will not respond to any of the above, artificial tears, lubrication, will need what we call punctal occlusion. Okay, so if you go back to the anatomy again, there is a particular, like the beginning of the lacrimal drainage system, the puncti. Good. Some people with very, very terrible or severe dry eye symptoms may require the blocking or the, sorry, I think I passed it. All right, so there are some small plugs that can be used to occlude the entrance to the nasolacrimal duct system. Okay, and that helps the little or like the small amount of tears the person is able to produce to stay on the eye for much longer. All right, good. And then the patient needs to be counseled about activities that can make the dry eye symptoms worse. Okay, so you tell the patient that if he's working on the computer, he should take frequent breaks. Okay, there's a rule we call 20-20-20 rule. This is something that if you tell your patient, they'll be very grateful for. Someone with dry eye syndrome who is always on the computer, always watching TV, tell them that they should take a break every 20 minutes for 20 seconds. And during that break, they should stare at something far away at a distance of 20 feet, okay? So 20, 20, 20. And during that time, when they are staring at something about 20 feet away, they relax their eye muscles and they also blink or like close their eye and open several times to nourish the surface of the eye, in addition to whatever medications you may be using for the dry eye syndrome. This behavioral or lifestyle change is also quite important, okay? All right. Then what you see here is someone with thyrotoxicosis, okay? And he has exophthalmos. And what is striking in this picture is you can see he has retraction of the upper lid, because in the normal eye you shouldn't see the clear space above the upper limbus. If you are seeing the white part above the upper limbus, it means that there is lid retraction, which is a very common sign in someone with thyrotoxicosis or hyperthyroidism. They sometimes, when you ask them to close their eyes, the eyes may not be able to close very well. So they will have exposure. They will have exposure keratitis that can also result in severe dry eye symptoms, and even it can also result in infection of the cornea, okay, what we call exposure keratitis. So this person will need to have the eyelids taped at night when they are about sleeping, and they will need frequent artificial tears to help keep the surface of the eye moist and healthy, okay? Yeah, so exposure keratitis, which can be caused by thyroid eye disease and facial nerve palsy, okay? They result in incomplete closure of the lid, and you manage with lubricating solutions and ointments. And then, like I said, you have to tape the lids shut at night, okay? If the exposure is so much, you have to refer. Then we have some growths on the eye that can also result in a dry eye. One of them is called pinguicula. It's cousin, because I'm saying cousin because they have almost the same underlying pathogenesis. Is pterygium, okay? So what you see here is a fibrovascular growth of the conjunctiva that has invaded the cornea, okay? That's the pterygium. It can become red, it can become inflamed. This one, sorry. So difference between a pinguicula and a pterygium is that a pinguicula is limited. It doesn't involve the cornea, okay? But a pterygium, the fibrovascular growth involves the cornea, like a triangular shaped or wing shaped fibrovascular growth that involves the cornea. This can cause a lot of pain. It can cause tearing. It can cause tearing because it makes the eye feel dry, because the growth on the eye, the upper lid is not able to evenly spread tears on the surface of the cornea. So the eye will feel dry, and the patient will come with sensation of foreign body, pain, burning sensation, and then tearing, like I have described already for dry eye syndrome. Okay, so let's take notes. This is pinguiculum. This is a pterygium. All right, they can be inflamed. When they are inflamed, they require some mild topical steroids, okay, like flumetolone, and then they require artificial tears because of the associated dry eye syndrome that comes with it, okay? Yeah. And then if you notice that it is really advancing or growing towards the center of the pupil, it can affect the vision. So you have to refer the patient to an ophthalmologist. Now I'm coming to the next session with the anatomical causes of dry eyes that involve the anterior segment of the eye, okay? So we started with the face, the external part that involved the eyelids, and then we came to the ocular surface. Now the anterior segment. What are some of the things that can go wrong here in the anterior segment that can give dry eye. Just a recap of our anatomy. So this is the cornea. Then we have the ciliary body here. Then we have the iris. Behind the iris, we have our lens. We have the pupil at the center of the iris. So what can go wrong? Okay. So starting from the cornea itself, when someone has disorders of the cornea, acute disorders of the cornea, like I mentioned, edema of the cornea or abrasion of the cornea or ulceration of the cornea, they can present with red eyes, okay? So the red eyes from pathologies of the cornea, patients will complain of pain in the eye as well as foreign body sensation, and they will typically describe the pain as deep, boring pain. They also have photophobia, and then most importantly, blurred vision, because the cornea needs to be needs to be have it needs to have a very smooth surface with very stable tear film layer for it to be able to perform its function of refraction. So if there is any problem with the surface of the cornea, blurred vision will result. Okay, so if you look at this, you know, when you shine light on the surface of the eye, the cornea has a highly reflective surface. Okay, that's the principle that underlines corneal light reflex. So the surface of the cornea behaves as if it's a convex mirror. Okay, so when the surface of the cornea is very smooth and you shine light on the eye, you should have a very clear reflection. Okay, and if I didn't say this during the other time, corneal light reflex can be used in diagnosing strabismus, especially if you have a child and you shine light into the two eyes. You expect that if the eyes are well aligned, the corneal light reflex should be at the center of the cornea. If the eye is deviated, then the corneal light reflex will not be central. So if the eye is deviated outwards, then you have the corneal light reflex closer to the medial limbus. If the eye is deviated medially or inward, then you have the corneal light reflex located to the temporal limbus, okay? But in this case, you see a very sharp, well-demarcated reflection. You can even look at your own image on somebody's cornea. If there is any abnormality on the surface of the cornea, the reflex will not be very good. It will not be smooth, as we can see in this picture. So the cornea is edematous, it's hazy, and the reflection is very irregular, okay? Yeah. So keratitis, or if there is aberration, and how do you pick if there is a corneal aberration or a corneal ulceration or an abnormality on the surface of or on the epithelium of the cornea? Is by staining with fluorescein, and as I said, you can use the fluorescein drops, or you can use the fluorescein paper strip that has been impregnated with a fluorescein dye. Okay, so if you are using the dye, after you have put your anesthetic drop, then you put the tip in between the lower lid and the globe, okay, and the tears will dissolve some of the fluorescein, and it will spread. If there is a pathology with the cornea, you find out that that part of the cornea is going to stain. The normal cornea doesn't stain with fluorescein. So this is very, very important. If you have any conjunctivitis, especially in children, please stain with fluorescein. If you stain with fluorescein and you see something like this on the cornea, it is an emergency. Okay, because this one can be potentially sight threatening. Okay, even when the ulcer or the infection resolves, there's going to be huge scarring in this place if it's not well managed. Okay, so a corneal aberration will stain with fluorescein when you shine a blue cobalt light on it. Okay, because the dye absorbs light of a shorter wavelength, that's the blue light, and will emit light of a longer wavelength, that's green. Okay, so blue light will shine on it, but green light is reflected. That's why you see that yellowish green stain on the cornea. So I think I've mentioned this signs of corneal aberration. So redness, the eye will become red. There'll be tearing, photophobia, pain, blurred vision. Okay, and sometimes because of the photophobia, there will be reflex miosis. The people will constrict in an attempt to reduce the amount of light that is coming to the eyes. And you find this in people who wear contact lens or people who have had an injury, trauma to the eye or anything, or welders. Okay, welders can have injury to their cornea and it can be very, very painful. When they come and then you stay with with amethocane, they'll feel relieved. But beware that they don't go about self-medicating with amethocane. That can actually destroy their eye. Okay. So what do you do? In this case, you want to promote healing, you want to relieve pain, you want to prevent secondary infection of the corneal aberration. So your treatment, you give um, um, cyclopentolate, which is a cycloplegic agent. So it helps to paralyze the ciliary muscles, okay? Because it's the ciliary muscles that are responding to the light and is giving that pain. So when you dilate, when you give cyclopentolate, it helps reduce the symptoms of photophobia. And then you give topical antibiotic eye drops as prophylaxis against infection. And then most people will want to patch, okay? Patching, I'll show a picture in which we have an eye patch. So you close the eye and then you put a pad and then you taper it nicely. You patch it for about 24 to 48 hours, okay? And the patient will feel very relieved whilst it's patched. And this will also promote healing of the eye. Chemical injury, another cause of red eye, very important, is an ocular emergency, okay? It requires immediate irrigation of the ocular surface with the nearest source of water. Okay, so ideally you want to use Ringer's lactate or normal saline. When it happens and you don't have any of those two, just use normal tap water. Okay, to wash the surface of the eye after you have applied your topical anesthetic eye drop like amethocane. You have to irrigate the eye copiously so that any particulate matter of acid or alkali left will be washed away. Okay. Yeah, and the management depends on what is causing it. So this is a picture of an eye that has suffered an acid burn. Okay. Acid burns are not as serious as alkali burn because with acid there like the acid leads to coagulation of the proteins and prevent further um, penetration of the offending agent, unlike an alkali, where there is rather liquefaction and it can cause the alkali to actually go deeper than it is. So alkali burns are usually more severe, they are more dangerous than than acid burns, depending on the quantity. So this one is an emergency. Irrigate copiously, and then in this case it is an emergency. So at your level, irrigate copiously, give your steroids, okay, because it's not an infection. Give your steroids to reduce the inflammation, and then you give your cycloplegics like cyclopentolate to help reduce the pain and the discomfort, whilst you immediately or urgently refer to an eye clinic where an ophthalmologist will see. Okay, so infectious keratitis, this is when we have infection, either viral or bacterial infection of the cornea, and like I've stated here, or stated there, it can cause permanent decrease in vision from scarring. After the infection resolves, there can be scarring, okay, and the cornea can become opaque. Even if the cornea doesn't become opaque, the cornea surface become irregular. That can lead to astigmatism and hence blurring of the vision. So it needs to be detected quite early, and then you start treatment aggressively. Okay, how do you detect it? So the symptoms: red eyes, they will have discharge, maybe purulent discharge if it's bacterial or watery. If it's viral, foreign body sensation, blurred vision, photophobia, okay? All those are classic symptoms. And what will let you confirm it is that the cornea may not look clear. If the cornea is clear, you should see the iris details very nicely. If the cornea is not clear, then you don't see the iris details, okay? And when you stain with fluorescein, you will see that a part of the cornea will pick up the dye. Or even before staining, if you examine the corneal light reflex, you see that the reflex is not regular because the surface of the eye is not regular, okay? Here's an eye with primary herpes simplex infection, okay? And then it can involve the eye. On the eye, if you have herpes keratitis, they have this dendritic ulceration of the cornea. It looks like a fan, okay? This is classic for herpes simplex infection of the cornea. When you stain and then you see this one. So in this case, steroids are a no-go area, okay? And then for most of what I've talked about, you don't give topical anesthetics. Someone who comes with a pain at the eye clinic, when you stain with the ametokin, the pain just vanished. They may look at the eye drop that you put on the eyes and then later go and buy some themselves and then continue putting it on their eyes, and that can result in damage to the cornea. So we have to beware that patients don't abuse topical NSAIDs. And then steroids too, as I said, is a contraindication if you suspect viral conjunctivitis or viral keratitis, okay? These are some of the side effects of steroids. So they worsen herpes virus infection. They can lead to the development of increased intraocular pressure, what we call steroid-induced glaucoma. It can result in the formation of cataract, opacification of the lens. And then if it is a fungal keratitis too, it makes the infection worse, just like we have for viral. There's an eye that has blood in the anterior chamber. We call it hyphema, okay? So blood in the anterior chamber is called hyphema. It could be due to trauma to the eye, or sometimes it could be spontaneous, like people who have maybe some development of new abnormal vessels on the iris because of ischemia or reduced blood supply to the posterior part of the eye, which you will typically find in people with advanced diabetic retinopathy or retinal vein occlusion, or maybe occlusion of the carotid artery. The ischemia happening posteriorly can result in the release of, hello?
Yes.
Yeah,
And then I
Cynthia.
get the treatment of the herpes simplex infection of the eye. What do we give?
All right, good. Sorry. I think, yeah. So for herpes, we give acyclovir, okay? We give acyclovir ointment, but it's also something. Yes, acyclovir ointment, but it's also one of the conditions. Sorry, I forgot to mention it. It's also one of the conditions that require referral.
Referral, okay.
Yes, because it can be complicated with keratouveitis, and it can be potentially sight-threatening. Okay, and it's something that the patient is going to keep going and coming for a long time. So when you suspect that, you can give your acyclovir ointment whilst you refer to see an ophthalmologist. Yeah, thank you for letting me. Is there any other question? If at any point you feel I have to clarify something, please prompt me.
Thank you, Doc.
All right. Okay. Yeah. So hyphema could be from trauma or from, spontaneously from new fragile vessels that are developing in the anterior chamber. Okay. And I said you have new vascularization or development of new vessels on the iris that can spontaneously bleed like this in conditions such as advanced proliferative diabetic retinopathy or vein occlusion or anything that will cause ischemia to the posterior surface of the eye. That ischemia will result in the production of vascular endothelial growth factors, okay? And elaboration of these vascular endothelial growth factors will stimulate the development of new vessels, but they are not as strong as the normal vessels. So they can bleed spontaneously, okay? Yeah, so what do you do when you have a case like this, a hyphema? So you have the blood, which is well layered here. What do you do? So from the history, if it's trauma, then it's likely that there may be other associated injury. This is also a cause of red eye that requires urgent referral to an ophthalmologist. Okay, so hyphema, whether it's traumatic or non-traumatic, requires urgent referral. Okay, so you take your thorough history to have an idea what is happening. If there's someone with diabetes for a long time, or a known hypertensive, or a known glaucoma patient, all these factors put the person at risk of a retinal vein occlusion that can result in development of new vessels, okay, and hence such spontaneous bleeding. All right, okay. All right, then we have some inflammatory conditions that can cause red eye, like episcleritis, and then anterior uveitis. The episcleral tissue is right on top of the sclera, okay? And they, in certain systemic conditions like rheumatoid arthritis and co, they may also present with scleritis or episcleritis. How do you differentiate between them? If it's episcleritis and then you put a drop of phenylephrine on the eyes, you see that the reddening is going to resolve because usually it's the superficial blood vessels that dilate. But in scleritis, a drop of phenylephrine does not affect the redness in any way because those vessels are a bit much deeper than you have in episcleritis. Okay, in both cases, you can give your oral analgesics like brufen, give some artificial tears whilst you refer to an ophthalmologist. If there is any underlying systemic condition, I think you have to manage it as well whilst you are managing the eye component with the ophthalmologist, okay? Very importantly, uveitis, or in this case, anterior uveitis, when it involves the iris or the ciliary body, what we call the cycloiritis, okay? Usually, uveitis can also present with red eye. But what is typical of uveitis causing a red eye is that the redness will usually be around the limbus, okay? What we call the circumlimbal redness. And the patient will present with pain, photophobia, and the vision is going to be decreased, okay? And the people will be myotic in reaction to the eye's inability to withstand light. Iritis or uveitis is an emergency. You need to identify this and refer. Unlike the other kind of red eyes, like conjunctivitis, where the whole conjunctiva may be diffusely reddened, in iritis or in anterior uveitis, the reddening may be more as you get close to the limbus. I hope that's clear. So they may be associated with certain systemic conditions or trauma or systemic infections or even autoimmune conditions like SLE. Yeah. All right. Now I'm coming to angle closure glaucoma. The last time I tried to explain what the angle is. So we have aqueous being produced by the ciliary body. The aqueous will pass through the pupil, and then it will drain through a sieve-like or a mesh-like structure between the cornea and the iris. We call it trabecular meshwork. Okay. Now that space between the cornea and the iris is what you call the angle. Okay. When someone has glaucoma, the glaucoma could either be open angle. In this case, this space is open, but the rest of the drainage of the fluid deep down here um, may not be very patent. But in angle closure, this space is closed altogether. So if you compare this diagram to this one, you can see that here, the iris, the peripheral part of the iris is pushed towards the cornea. So you can't even get access to the trabecular meshwork for the aqueous to drain out of the eye. This will cause the eye pressure to increase significantly and can lead to corneal edema. That can lead to severe pain, headache, nausea, frontal headache, typically. The patient may even vomit. Vision is going to be blurred because of the edematous nature of the cornea. You require the cornea to be clear before you can see well. And then the patient may typically complain of halos around lights, sensation of rainbow around lights. Okay, that's because of the edema of the cornea, and the eye is red. Okay, in acute angle closure glaucoma, the eye is red. There is pain, severe headache, vomiting, and nausea. The pupil becomes fixed and dilated. Okay, and the intraocular pressure is very high. If you have means of checking the intraocular pressure with either the tonopen or eye care tonometer, or some people have the SHOS. Okay, if you know how to use it, you can use it to estimate the intraocular pressure. Or even
Okay,
if you
Doc.
don't have,
Yeah,
hello,
15 minutes
Cynthia.
to time. Just to remind
Oh,
you, you said we should remind you.
yeah,
15
thank you
minutes
very
to
much.
time.
All right, I'm almost at the end. I'll run out
Okay.
soon. Thank you. Yeah, so if you don't have any of these instruments to measure your eye pressure, you can use your fingers to do digital tonometry. Okay, so just with the patient's eye closed, you can palpate the eyeball between your fingers. Okay, so you check how firm one eyeball is compared to the other. That is, if the acute angle closure is happening in one eye. Okay, so that is digital tonometry, not the best, but where you don't have any means of checking the pressure, that is what you can do. So this an eye with angle closure glaucoma. Is red, cornea is edematous. Okay, and you can see that the cornea is edematous because you are not seeing the iris details very clearly. The iris appears hazy, and the corneal light reflex appears to be irregular. Okay, so it means that the cornea is not smooth. So this is also an emergency. You need to refer to an ophthalmologist, because beyond your treatment that will relieve the patient of the pain and everything, something needs to be done to prevent future attacks. Okay, but this is what you can do initially. You can give pilocarpine eye drop 2% every 15 minutes, about 2 times. You give timolol eye drop, then apraclonidine. All these are anti-glaucoma medications with different mechanisms of action. You are aiming to reduce the pressure as much as possible. Okay, apraclonidine is an alpha blocker, whereas timolol is a beta blocker. Okay, yeah. Then we have acetazolamide. You can give it orally or intravenously. It is also a carbonic anhydrase inhibitor that helps reduce the production of aqueous. Then you can also give your IV monitor, just like we give in cases where you have increased intracranial pressure. It will help to, by the process of osmosis, help to drain so much water from the eyeball and relieve the patient of the pain and discomfort. Okay, so I'm coming to the end. These are some of the red eye disorders that treatment will be indicated. Okay, so hordeolum, chalazion. I said for these two, usually warm compress. For the hordeolum, if there is an associated fever or the tenderness is too much, then you may give some eye ointments or some oral antibiotics, but mainly warm compress will do. You may give some artificial tears to help make the eye surface comfortable, just like we have for blepharitis. Okay, conjunctivitis, it depends on the cause. Okay, whether it's infective or non-infective, and if it is infective, whether it's bacterial, viral, or allergic. Okay, those are what will determine how. Subconjunctival hemorrhage may not require treatment, like I said initially. It depends on what is causing it. You may have to just treat the underlying cause. Dry eye syndrome will require treatment. It will help the redness. Corneal abrasion, most importantly, treat and then refer. Okay, so these are the vision-threatening red eye signs and symptoms that you need to refer. So one, if vision is decreased, or if the red eyes is associated with ocular pain or photophobia or circumlimbal redness, if the redness is localized close to the limbus of the eye or of the cornea, it could be a sign of iritis or uveitis. You will have to refer. If there is corneal edema, you have to refer. Okay. If you have means of checking the intraocular pressure and the pressure is high, you can give your acetazolamide, you can give your timolol, you can give your pilocarpine whilst you refer. If the person has corneal ulcers, you have to refer. If there is no corneal ulcer and it's just conjunctivitis, it can be managed at your level without having to refer. If the pupils are abnormal or if the pressures are high, you have to refer. Okay. These ones are urgent. They need urgent referral. Like I've already mentioned, orbital cellulitis, if there is scleritis, okay, because the scleritis can actually result in some posterior complications and let the person lose the vision. So unlike episcleritis, which you can manage with some oral NSAIDs and some artificial tears, scleritis needs referral. Chemical injury, after your first aid of irrigating the eye copiously, you have to refer. If there is infection of the cornea, keratitis, it needs referral. Iritis, acute angle closure glaucoma, and hyphema need referral. Okay, yeah. So this is just a summary. So conjunctivitis, if there is discharge in both eyes and the cornea is clear, so you stain the eye, the cornea is clear, the pupils are normal. This one, it can be managed at your level with some antibiotics or maybe just, if it's viral, just some artificial tears. Don't give steroids if it's viral. If it's corneal ulcer, you have to refer, okay? You give hourly. Your antibiotics should be given very frequently, okay? Like I said, for ophthalmia neonatarum, if it involves the cornea, very frequent topical antibiotic drops. If there is iritis or uveitis, so you have the reddening more closer to the limbus, not very typical in this case, but you have to refer. You can give your cyclopentolate to relieve the pain, then you refer. The same thing with glaucoma, okay? Yeah, so managing red eye, you have to collaborate with the ophthalmologist, okay? And it will depend on your clinical expertise, your cooperation with the ophthalmologist, as well as how you communicate. The reason why we are having these lectures is so that if you have a red eye and you call me or you call any ophthalmologist, you know exactly what is important for the ophthalmologist to know to decide whether it needs urgent referral or not. All right, thank you very much. These are the resources. I have some picture. So I have some picture quiz if time allows. Can you see this particular picture? What is wrong with these eyes? Look at the picture. So it's a 14-year-old boy who complains of itching of the eyes for 3 years. And currently he presents with a sticky clear discharge. His visual acuity is 6/6. What do you think is wrong?
Eyelid. So
Yeah, so on the eyelid, you have these swellings, cobblestone appearing swellings, papillae on the eyelids. Yeah, any help?
yeah. So in this case, we will have to use the split lamp to rule out blepharitis too.
Okay.
And yes, and to also, the picture is not really clear. So
Yeah, but look at the history. It's a 14-year-old boy who complains of itching eyes for 3 years with sticky clear discharge.
okay.
Is it an allergy?
Very good. So allergy will usually present with recurrent itching of the eyes. And when you vet the upper lid, you see these papillae, okay? These swellings, cobblestone swellings for people with severe allergic conjunctivitis. Okay?
Okay.
All right. Very good. Very good. This one to the next picture. It's a 45-year-old female complains of painful eye and discomfort in light with watery discharge. What do you think is wrong? By the way, look at the cornea. What do you see with the cornea?
It seems swollen.
Yeah, the cornea appears edematous. It's not very, very, very clear because you can't see. You can't see.
Opacification too.
Yes. Yeah, and then the corneal light reflex is not very regular. Okay, it appears irregular. So it means that the what do you call it? The cornea is a bit what do you call it? Edematous. Okay, and yeah, someone mentioned if you look at the redness, it appears to be more reddened closer to the limbus. Okay, so in this case, it is typical for an acute anterior uveitis. So this kind of red eye presentation needs referral. Okay, maybe let's look at 2 more pictures and then we go. So this is a 5-year-old girl who presents with severe pain and loss of vision for 3 days. They used topical traditional eye medication about 1 week ago, and the vision is counting fingers. By the way, what do you see? Can someone describe it? This is obviously a red eye, but what else do you see?
Like
so I might see tearing, a watery red eye, and the cornea is not clear. It's also opaque. And the red reflex is also irregular.
So usually for the use of traditional eye medications, some of them may contain, not sterile. Okay, so it may actually introduce infection to the surface of the eye and cause keratitis. Okay, so infection of the cornea. When there is keratitis, the cornea becomes edematous, the cornea becomes cloudy, and of course they'll have pain, photophobia, loss of vision. The eye can even perforate. Okay, all right. So that is a case of keratitis. Okay, there was infection. So the eye is red and the iris cannot be seen clearly, which suggests that the cornea is cloudy. So
Yes.
if you want to see whether the cornea is clear or not, it depends on how clearly you can see the iris. If you can see the iris details clearly, it means that the cornea is clear. If you can't see the iris details well, it means the cornea is cloudy. Okay. All right. I think we shall end here. And then if any of you have any questions, since we have just a few minutes left, I'll make the slides available. So if there is any question, I know it's quite a lot, but please take time to read and go over this in some of your textbooks. Most of these common cause of red eyes will be discussed, and for the period together, we can always discuss it so that you gain more understanding. All right. Thank you very much for your attention. Is there any question?
No,
Very much.
already asked during the presentation. Thank you
All
so
right.
much. Yeah.
You're most welcome.